Very good morning, everyone. It's a pleasure to welcome you again on the third masterclass in Masterclass Series 2 of Indian Society of Gastroenterology. As you're aware that this time in the Masterclass 2, we are discussing the clinical case scenario and mainly directed towards our trainees in gastroenterology, both DM and DNB. So this was a thought came some time back that after we had a first masterclass series, that we should have some clinical case discussion, and therefore we took this decision to do at least 12 classes for clinical case discussion, and this is third in series. Last week we discussed a case who had a large bowel diarrhea and intestinal obstructive disease, but this year we'll discuss a case. This session today we'll discuss a very important case of chronic constipation and how do you approach. I know chronic constipation is a very, very common disease. And we see that too in very commonly in our clinical practice. Therefore, it's very important to know about how do you approach a patient with chronic constipation. There are a number of confusion in the terminology, various terminology we use in chronic constipation, and furthermore, the approach. So therefore, we took this decision that let's dedicate one masterclass to how best we approach a patient who comes with chronic constipation of short duration, mainly for long duration. How do you approach that? And to do this, we have this masterclass where we have two great teachers, Dr. Amit Datta. He's a professor of gastroenterology at CMC Vellore. And we have Dr. Praveen Rathi, again, one with a distinct teacher and from Mumbai. I will also join in the discussion in between. And to facilitate today's masterclass is Dr. Sridhar, very, very active, a young member of our society. Not so young, but again, he's a consultant at Tata Memorial Hospital in Mumbai. Very dedicated and very efficient. You will see that how well he performs today. To do the two cases, we have two, again, bright residents who are second-year residents from CMC. And may I request Dr. Amit to please introduce both the residents who will discuss the case.
Thank you, sir, for the kind introduction. And first of all, I'd like to thank ISG, Dr. Govind, Dr. Rakesh Kochar for providing us this opportunity to discuss this case of case series today, two cases. And you've already been introduced to the panels. So the cases today will be presented by a couple of our residents. Dr. John Titus will present the first case and Dr. Nicholas will present the second case. So as we all know, as Dr. Govind has said, that chronic constipation is actually a very common problem we see almost every day in our practice. And the nature of the symptom, the severity of symptom really varies, and you have diagnostic tests, you have therapeutic modalities, but you need to make a decision that which person should be investigated, how much, how should we manage a patient. Most patients do not require a lot of investigation. Okay, so therefore, a very good clinical approach is essential, which means a good history followed by examination, and then you can decide on how to proceed further. So we'll start with the first case to be presented by Dr. John Titus. Over to you, John.
Amit, one more thing I want to highlight, that this is a case discussion we are doing like a panel, and we'll request all the participants to ask questions in the chat box. So write your questions. So we'll try to respond as many questions as possible. This is number one. And number two, there will be certain poll questions. So do participate in putting a response to the poll questions. And we go by now, the Amit. Yeah.
Thank you so much. Yeah, definitely. Okay, so I think we can start with the first case discussion by Dr. John. Yeah. So John, we can't hear you. Are you muted?
Sorry. Presenting a 24-year-old male who is an MA student from Patna, who complains of constipation for the last 6 years. So he was well till 6 years back when he noticed a decrease in frequency in his stool over a period of a few months. He complained of passing stools only once in 5 to 7 days. His stools were lumpy and pellet shaped, corresponding to a Bristol stool form scale of 1/2. He had a feeling of incomplete evacuation of stools, and he had to strain while passing stools. He also complained of abdominal bloating when he did not pass stools. He did not perceive an obstruction or blockade in the anal canal. He does not have any he did not have to use any maneuvers to facilitate defecation, and he did not have a strong urge to defecate. He did not have abdominal pain, and his abdominal pain, we specifically asked for pain which was triggered or relieved by bowel movements, which was not there in this patient. He did not have history of blood in stools. There was no mucus in the stools. He did not have vomiting, and there was no history of alternating loose or hard stools. He did not have any coexisting dyspeptic or reflux symptoms. There was no history of weight loss, and there was no history of prolonged fever. Treatment history. So at the onset of symptoms, he tried isabgol powder for 6 months. However, with this, he only had a partial response. His Bristol stool form increased to more than 3. He was passing stools around 3 times a week. However, he continued to have a feeling of incomplete evacuation of stools, and he still had to strain while passing stools. He later then took lactulose syrup for around 6 months. Again, he had a partial response with the same. He then tried Ayurvedic medications for 2 years and later tried homeopathic medication for 3 years. With both, he had only a partial response. He also tried magnesium containing laxatives and lubricants, with which he had a partial response. And his stool frequency had only become 3 to 4 times a week, and his feeling of incomplete evacuation persisted. This is the timeline of his laxative usage. So, as I mentioned, he had used isabgol powder initially for some time. Later on, he used lactulose, after which he used Ayurvedic medications. Then he changed over to homeopathic medications. He tried magnesium salt laxatives for some time at the same time. However, he only had a partial response with the same. There were no symptoms to suggest neurological dysfunction. Symptoms like lower limb weakness, bowel or bladder issues. We asked specifically for this history. He did not have any such problems. There was no comorbid illnesses like diabetes mellitus, hypothyroidism, or systemic hypertension. There was no history of taking any regular medications like calcium channel blockers, antipsychotics, or opioids. He did not have any surgeries in the past, and there was no history of spinal cord injury. Diet history: he was consuming a predominantly vegetarian diet. His calorie intake was 1,500 kilocalories with 40 grams of protein. He had limited fresh fruit and vegetable intake, and his fluid intake was adequate, around 2 to 3 liters per day. His personal history: he did not have any addictions like smoking. He had a physical activity of walking around 45 minutes to 1 hour every day. He is currently pursuing an MA degree. He did not have any history of anxiety, depression, or other psychiatric illnesses. He did not consume any psychiatric medications. His personal life and studies were adversely affected by this illness. His family history: there was no family history of GI malignancies, and there were no similar complaints in the family. So, summarizing the history, this is a 24-year-old male with no comorbidities or addictions, with constipation for 6 years, with a history of incomplete evacuation of stools and straining to pass stools, with no alarm symptoms or symptoms suggestive of systemic illness. He has tried multiple laxatives, with which he has had only a partial relief of symptoms.
I guess after the summary, we have a couple of questions for the audience poll. So this is the first question. If you can just put up the poll. So which of these is not an alarm symptom in a patient with constipation? Age less than 45 years, recent onset constipation, weight loss, family history of GI malignancy, and change in stool caliber.
We don't have choice 5. Choice 5 is just a vacant space.
I think it's change in stool
Change in
caliber.
stool caliber, sir.
Okay.
Change in stool caliber.
Yeah. Okay. So I guess this was a simple one, and so I guess all of us know that. So majority, like expected, 92% have answered that age less than 45 years is the right answer. So just to reiterate the alarm symptoms in constipation, because this is very relevant as a clinician to know. So age more than 45 years, change in stool caliber, any blood in stool, unintended weight loss, fever, history of GI malignancy in the family, any iron deficiency anemia, recent onset of constipation, any rectal prolapse or rectal bleeding, vomiting, and loss of appetite. All of these are alarm symptoms and something that all clinicians should look for in a patient who presents with constipation. So coming to the next question for the poll. So as per the present history that has been given by Dr. John, what do you think is the type of constipation in this patient? So normal transit, slow transit, dysenergic defecation, mixed type, or none of the above, the possible organic etiology. So I think we are going to have a mixed bag. Okay.
Sridhar would like to tell the response
Yeah.
to. I'm not sure they are able to see the
So
poll results.
out of 145 people who've answered, 55% felt this was slow transit, 17% felt this was dysynergic defecation, 12% felt it was normal transit, and 12% felt it was a mixed type. 3% felt that there was a possible organic etiology here. So majority went with slow transit and 17% with dysynergic defecation. So just to a brief primer on the Rome 4 has defined functional constipation based on these symptoms, wherein you have to have 2 or more of the following 6. That is straining during more than 25% of the stools. They usually ask to maintain a chart for a week. And lumpy or hard stools in more than 25% of defecation, sensation of incomplete evacuation for more than 25% of defecations, sensation of anorectal obstruction or blockage, manual maneuvers to facilitate more than 25% of defecation, and fewer than 3 spontaneous bowel movements per week. Now, the loose stool should rarely be present without the use of laxatives, and they should not fulfill the criteria for IBS. And these criteria should be fulfilled for at least 3 months with symptom onset at least 6 months prior to the diagnosis. So functional constipation is again divided into 3 types. Normal transit, wherein all the physiological tests are normal, except maybe the barostat, which may be abnormal. Slow transit constipation, wherein there is decreased in the phasic colonic motor activity, and dysynergic defecation, wherein there is poor coordination between pelvic floor and anal sphincter function. So there can be considerable amount of overlap between these, but again, these are broad categories. So as a student, it is important because this might be asked in the exam, what is the normal physiology of defecation? So the normal physiology of defecation would involve the stool passing into the rectum with sensory perception of stool. The rectoanal inhibitory reflex leads to a relaxation of the internal anal sphincter. Subsequently, if the situation is appropriate, there is a contraction of the diaphragm, abdomen, and rectal muscles with relaxation of the external anal sphincter, and relaxation of the puborectalis, which straightens the anorectal angle and facilitates for passage of stools across the anal sphincter. So you can see in the defogram photos also that the anorectal angle initially acute, after the relaxation of the puborectalis and the becomes straighter. So this is the normal physiology of defecation, which may be asked in the exam if you get a case of constipation. So Last question for the poll before we go on to the examination. So what proportion of Indian patients with chronic constipation have dyssynergic defecation? Okay, so out of 100 and can I think end the poll? Yeah, so 159 people have answered, and the majority 53% feel it is 20%, 37% feel it is 40%, 9% feel it's 60%. The answer is 40%. There were two studies, both of which showed a figure that was roughly close to 40%. One from Mumbai, which showed the figure was 40% exactly, and one from SGPGI, which showed the figure was 36%. So there are some pointers to dyssynergic defecation that we have to look for in history. So there has to be a history of incomplete evacuation, excessive straining, sense of anorectal obstruction or blockade, and the need for maneuvers like fingering or a vaginal pressure to evacuate. The stool frequency may be low in these patients, not necessarily always they will have re-urge, and there might be history of obstetric trauma or sexual abuse in these patients. I think we'll go to the diagnosis. I think John, you can.
So John, we need to know, based on whatever you have taken history from this patient, what's your complete diagnosis? Can you tell us your complete diagnosis, John?
Yes. So at the end of history, I would the diagnosis would be, the syndromic diagnosis would be that of a chronic constipation. Etiology I would put as probably functional, and the type of constipation he had features suggestive of an incomplete evacuation of stool. He also had straining to pass stools. However, he did not have a persistent urge to pass stools. So first I would consider dyssynergic defecation. However, I would also keep a slow transit constipation in the back of my mind. He also did not have, he had only a partial response to bulk forming, osmotic and alternative medications. He did not have comorbid illnesses, and he did not have any concomitant drug intake.
Thank you. That's good, John. So Dr. Rathi, do you want to ask some questions to John at this stage?
Dr. Rathi, want to ask, or Amit, you continue.
Yeah. So then, John, so I think the first question, John, I want to ask you is that, so let's go by, so obviously constipation is something. So how do you objectively say that the patient has constipation, John? What parameters you look for? See, constipation, the patient will tell you that I have constipation. So how do you differentiate a subjective constipation from an objective constipation?
We look at the stool frequency. So this patient had a stool frequency of passing only once in 5 to 7 days. Less than 3 per week is generally taken as constipation. The second factor is the Bristol stool form scale.
Yeah, very
constipation, we would expect in Indians up to 3 is taken as constipation. However, in the Western literature, up to 2 is taken as constipation. And the other associated symptoms which can further classify as urge and anorectal blockade.
So essentially what you're saying is because the stool frequency is low and the Bristol stool form is showing type 1 or 2 in this patient. So these are very strong pointers for objective identification of constipation. Now, why did you say it is functional? Why not organic in this particular situation?
So he's a 24-year-old male. We had asked specifically for other comorbid illnesses, which he did not have. He did not have hypothyroidism. He did not have diabetes. He does not have the asked for history suggestive of a neurological dysfunction. He did not have limb weakness or sensory abnormalities. And other issues like we asked for drug intake. He did not have any significant drug intake like calcium channel blockers, opioids, or specifically antipsychotics, which could have caused this. And hence, we would consider functional in him.
So basically what you have said is those secondary causes, but how did you say it is not any other organic colonic pathology causing constipation? So those are the secondary causes which, as you say, but how did you say it's not an organic colonic condition causing this problem?
He did not have any alarm symptoms, which would suggest
so what alarm features you say? What alarm? You can just want to reiterate that. What alarm features you asked for?
So one is loss of weight, blood in stools, recent change in caliber of stools and or abdominal pain. This would be one of the features which would suggest
Sure, that's good. See, now if you look at the audience poll, most of them actually now voted for this slow transit or the other ones, I think. But you're saying it's most likely a dysynergic defecation. So why do you say it's a dysynergic defecation in this particular patient?
So the points in favor of a dysynergic defecation are that he had a feeling of incomplete evacuation of stools, and he also had to strain while passing stools. But a point against it is that he did not have a persistent urge to pass. But however, in some patients, this may be absent. So because of these two, these history, I would consider that as the first differential, and then later I would also consider slow transit constipation and look for it.
Dr. Govind, sir, you want to ask any question to John at this stage?
No, I think that's fine. Only thing that a lot of our participants felt this is a slow transit constipation,
Yes.
not the pelvic dyssynergia. So it's very important to differentiate these two conditions in clinical practice. Please remember one point that every disease has a spectrum. And the classical manifestations, which are our textbook writes or we have been taught from early part of our education in medicine, that think as disease advances, the symptom and signs become more classical, and they are defined as a definitions of a particular disease. Please remember, every disease has to go through a spectrum of its illness, and therefore many patients can have overlapping features. As they become classical at the end spectrum, as far you go in the disease duration, you find more classified symptoms, more classical symptoms. But earlier you can have overlap, and we need to keep in mind as a specialist, because a patient will come to us at a different point of time in their disease course. Some will come midway, then symptom signs may not be so classical. Some will come at end stage, where the symptoms and signs are very classical, and some will come early, which may overlap with a normal habit. For example, constipation. We believe that if you ask constipation in a population, almost 50% of our people will say, I'm constipated. But he put into wrong definition, which Dr. Siddharth, Dr. Sridhar and John, and I mean, just discussed that chronic constipation, if you put them into criteria of round 4 or any definition, then only 10 to 15% patient will have a typical constipation. 30 to 40%, 30% of people just have a perception of constipation. They don't have constipation actually, but they feel that they have constipation. And this I name as a perceived constipation. I believe I'm constipated, but naturally it is not a constipation. And this is very important to differentiate. A lot of patients will come to us that I'm constipated, but you ask them, they say, I pass stool every day. There's almost normal caliber, but I want to pass 3 times a day. So I have to go 3 times a day in the morning. So, and they call it constipation. So please more and dissect out the type. And this is the thing which can help differentiate this is a perceived constipation or organic constipation. Perceived organic means functional constipation. Perceived constipation may not require any treatment except for reassurance, whereas the other constipation, like those who have fulfilled the defined criteria for constipation, certainly will require some amount of pharmacological therapy, and some will require investigative approach.
Thank you, sir. That's a very important point. In fact, I think I looked at the study done by your group also, where you found that the perceived was so much higher in the population in that Ballab and the Haryana area compared to this thing. So there are a couple of questions in the chat box before we proceed further. I think Dr. Jayanti has asked that, does this patient have any, John, any other investigations also apart from the history, which any investigations done before he came to CMC for his symptoms of constipation? Any specialized tests done or something?
So he had a metabolic workup done. So thyroid function tests were normal outside, and basic blood, so CBC and electrolytes and sugar levels were done, which were normal.
He had basically all the metabolic tests done, but no other thing for a structural. Okay. There's another question also, John, which is very important actually, again, which you presented, because in your history, you were saying patient had partial response. So the question is, how do you assess response to laxatives? Is there any definition to do that?
One we can assess is based on both the symptoms and maybe looking at the Bristol stool form scale. So like this patient, after giving laxatives, he had a change in his Bristol stool form scale from 1 to 2 to more than 3. However, his symptoms persisted. Though his bowel frequency also increased, his symptoms persisted, like he still continued to have a feeling of incomplete evacuation. He still had to strain to pass stools. So because of these parameters, I would say he had only a partial response to the laxatives.
So that's again a very important point. Yes, sir. So
if you can add, if you look at all the clinical trials in constipation, they would say 30% improvement in spontaneous bowel movement
yes,
on the baseline. So 30% means, again, you look at a chart of let's say, visual analog score, and if the 30% increase improvement with one intervention, they are classified as a improvement in constipation.
Yeah. So essentially, I think so. What we have discussed is like, see, when you ask history for constipation, there are these parameters to ask about straining, the urge, manual maneuvers, all that. So again, the bowel movements per week. So when you are assessing response, the same things you have to go back. Whatever problems patient had at the presentation in terms of his stool frequency, in terms of the consistency, digital maneuvers, training, feeling of incomplete, those are the same parameters you assess when you are assessing the response. And as Dr. Govind was saying, that in clinical trials, the most commonly used parameter is a complete spontaneous bowel movement. And they look at a CSBM of at least 3 or more per week as one of the endpoints in trials, actually. But for our patients, remember, apart from bowel movement, other perception thing is also very important, because if those are not improving, then the patient's quality of life may still not be better. Even though you have 3 movements a week, it may not be very, patient may not be still feeling much better than what he was earlier. We have Dr. Praveen to ask anything, or shall we proceed further? I think we are having some problem with his link.
Yeah, am I audible?
Yes, sir. Now you're. Yes, sir. Please go ahead, sir.
I think my video is not there. Okay.
So we can hear you very clearly, sir. Please go ahead. Yes.
Yeah. Okay. Continue then.
No, sir. Please, so you can ask some questions, sir. Please ask some questions, sir, at this stage.
So no, just now I've joined, so I don't know. We have finished up to what?
So John has just now given his history, and this is the diagnosis, the syndromic diagnosis he has put at the end of his history. Okay. So we have discussed about these things. So do you like to ask some questions on this syndromic thing, or we can proceed further?
I think we can proceed.
Okay. So then let's move on to the examination. Yeah.
On examination, his pulse rate was 84 per minute. His blood pressure was 110 by 70 millimeters of mercury. His respiratory rate was 16 per minute. His height was 164 centimeters with a weight of 57 kgs, and his BMI was 21.2 kg per meter square. There was no parallel express clumping cyanosis, lymphadenopathy, or fetal edema. His thyroid was not palpable. On abdominal examination, on inspection, the abdomen was scaphoid. All quadrants were moving equally with respiration. There were no visible masses, no scars or sinuses, and there was no visible peristalsis. On palpation, his abdomen was soft, non-tender. There was no organomegaly. There were no palpable masses, and there was no free fluid. His liver span was 15 centimeters, and he had normal bowel sounds. His CNS examination, higher mental functions, cranial nerves were normal. Motor power was 5 by 5 in both the upper and lower limbs. His deep tendon reflexes were normal, and his sensory examination was normal. His cardiovascular system and respiratory system examination were also normal. His perectal examination, on inspection, the perianal region appeared normal. There were no skin tags, there were no external hemorrhoids. On palpation, there was no tenderness, there were no fissures, and anal wink reflex was present. His rectum was loaded with stools. His squeeze pressure was good, and he had a sphincter relaxation while bearing down, and his perineal descent was not abnormal, and there was no blood on the gloved finger.
John, before we come to the question, you said perineal descent was normal. How much is the normal perineal descent?
So up to 4 centimeters is normal, sir. Less than 1 centimeter or more than 4 centimeter would be abnormal.
So what is the landmark, John, we use to assess that? I mean, when the patient is a left lateral, what landmark you use to assess that?
So we can look. We should take the ischial tuberosities as a landmark and
So
assess
if
the
it comes
perineal
below ischial tuberosity, then it is considered abnormal descent. Good. Yeah. Okay.
Very good.
So we're going to a poll question again now. So what is the positive predictive value of digital rectal examination for the diagnosis of dyssynergic defecation? Okay, we'll stop the poll now. So 160 people have answered, and majority, I mean 44% have answered 80%, 23% have answered 50%, and 22% have answered 30%. So the correct answer is 80%. This is a study by Mayank Jain, published in 2018 in the Indian Journal of Gastroenterology. So the steps of digital rectal examination become of utmost importance, especially because this is something that will be asked you if you get a case of constipation in the exam. So this has been explained well.
See, this is not about exam only; it's about practice.
Yeah, absolutely.
This is
Absolutely.
the exam. I didn't think exam is the one thing. It's just a one-time event, but it's a lifelong treating constipation. So good to understand that.
True, sir. So, so of course, the first and foremost, we have to explain the procedure to alleviate any fear or anxiety that the patient has. Subsequently, we have to have a good inspection with the patient in the left lateral position with the hips flexed to 90 degrees. We inspect the perineum for any excoriation, scar, tags, any condyloma, any external hemorrhoids, any fissure or fistulous opening or rectal prolapse. We evaluate for the perineal sensation and the inocutaneous reflex. Subsequently, we do digital palpation with a lubricated glove finger into the rectum. So we feel the mucosa, the surrounding muscle, bone, and adjoining structures. We evaluate for any tenderness, spasm, mass, rectocecal stricture, shell for hard stool. Lastly, we go do some maneuvers to assess the anorectal function. So we assess the resting anal sphincter tone, the anal canal length, the anorectal angle, any defect in the anal sphincter. We ask the patient to squeeze and evaluate the squeeze pressure. And in addition to a finger in the rectum, we place a hand above the abdomen and ask the patient to bear down as if to defecate. And we evaluate the push effort from the abdominal muscles, the relaxation and contraction of the anal sphincter and the puborectalis, the perineal descent, and also if there is any interception or prolapse. And lastly, when we take out the finger, we look for any blood on the finger. Okay, so I think John, you can.
So John, now that you have done your examination, you had your findings. Does it change your diagnosis or anything you want to add? What's your diagnosis now, John?
So the syndrome will remain the same, chronic constipation. Etiology will be probably functional. However, on rectal examination, I found that his sphincter was actually relaxing when he was bearing down, and hence I would also bring in a differential of a slow transit disorder along with the dyssynergic defecation.
Yeah. So Dr. Rathi, Dr. Govind, any question? Dr. Rathi, anything you want to ask me at this stage?
John, can you tell us the 4 types of dyssynergic defecation proposed by Dr. Rao on manometry?
Okay. So there are 4 types. Anorectal dyssynergia type 1 is when there is adequate, the rectal pressure increases, and paradoxically the anal sphincter pressure also increases. In type 2, the rectal pressure is does not increase, but the anal sphincter pressure also increases. In type 3, the rectal pressure increases, but the anal sphincter relaxation is inadequate. That is, it reduces only to less by around 20% of the basal tone. And in type 4, there is rectal pressure is also inadequate, and the anal sphincter relaxation is also inadequate.
Yeah, that's right. Yeah.
Okay, good.
Dr. Govind, anything you want to ask him, sir?
No, this is fine. So the only question comes that can you go one slide back?
Yes,
looking at the PR and examination, is important. And although many of us or most of us do not do PR examination, but sometimes PR give a lot of information. The point which John made, that squeeze pressure tells you that this is external sphincter. Squeeze pressure means external sphincter pressure. And one important point which made John to reconsider his diagnosis from pelvic floor to slow transit as a differential was the point which we found sphincter relaxation while bearing down. This is normal phenomena. So as you patient try to pass stool, the sphincter should relax. But in pelvic floor dyssynergia, the sphincter will contract. So this is called paradoxical contraction of sphincter. And this is a very important sign. In a patient with chronic constipation, if you do a PR and ask the person to bear down over your finger, and you find rather than relaxation, and this is a contraction of a inner sphincter, you feel squeeze, you feel pressure over your index finger. It means there's a dysfunction of relaxation of inner sphincter. And this is called anismus, and altogether called pelvic floor dyssynergia or dyssynergic defecation. So this sign itself tells the diagnosis even in the outpatient that this looks like a dyssynergic defecation. You can go and confirm by doing physiological testing, but this is very important sign. Similarly, if you find that pelvic descent is inadequate or more with a rectal prolapse, so this particular examination adds a lot of value to diagnosis. And those people who work on this GI physiology, they believe the importance of constipation, importance of PR in making a diagnosis, right? And third thing was a third thing said rectum is loaded with stool. It means what? Stool is coming to rectum, but rectum is not able to evacuate it. Why the rectum will be loaded with stool? It means either the muscle of rectum is not able to contract appropriately to propel the stool out of rectum during the process of defecation. Number two, if there's a relaxation of anal sphincters, which does not allow a sphincter to relax, and patient has to really put in strain to pass the stool. The straining is important, that the patient has to put a lot of strain in passing stool. It means there is some problem at anorectal physiology. So, and longer the stool stays in rectum, the stool become drier, and drier stool are difficult to pass. So these are the pointed towards pelvic floor dyssynergia in this individual.
Okay. So I think, so what I think is clear so far from the discussion of history and examination is that, constipation, while we see commonly, there are so many points to evaluate in a patient who comes to us with constipation. There are a lot of elements in history to be covered. Then examination, especially rectal examination, is so important. And if you do things properly, adequately, you will come to a conclusion about the underlying nature and severity, which will really help you in channeling your investigations further. So now I think we'll move on next to the investigation. So John, how would you like to investigate? So this is a patient which you have presented now, which was not responding well to the laxatives you told us. So how will you like to proceed in evaluating this patient?
So first, I would like to rule out metabolic causes. So I would like to do a TSH level in him, a calcium level, blood sugar level, and basic HB and platelet count.
So these are the tests. So how do you, what's your interpretation of this test?
So there is TSH is normal, sugars are normal, calcium levels are normal. So the basic metabolic workup is negative. So then I would, because he has chronic symptoms, he has partial relief to laxatives, and the symptoms are going on for more than 6 years. I would like to confirm my diagnosis, ask for more specific tests. So the first test I would like to ask for is a
before discuss, just to ask you, let's say if you saw a patient routinely in OPD, forget this patient you are seeing. If you saw a patient routinely in OPD who's come to you with say constipation for about a year actually, and then he's not taken, I mean, he's just taken 1 or 2 laxatives, these investigations are normal. So in that patient, will you proceed to further investigation, or basically when do you decide? The question is, when do you decide that you have to go for further tests, and when do you think these tests are sufficient?
So if a patient is having refractory symptoms, his symptoms are not improving with laxatives and has tried multiple therapies, At that point, I would like to try, I would ask for different investigation. However, if that is not the case, I would give him a trial of, I would explain physiology of defecation. I would reassure him, advise lifestyle modification, and give him a trial of laxatives. And if he improves, I would not proceed further.
So that's a very important point for everybody to understand that, constipation being a common problem in most patients, we don't have to proceed to higher tests. The simple baseline test, ruling out a secondary cause, looking for metabolic is enough. And then you can proceed to management. And more than 80% of cases will fit into that category. It's only in a select group of patients where you need to proceed further for further tests. And that again, you will be well guided properly if you do a good history and examination to decide which patient I need to go for next investigation, which patient I can stop and start treating. So as John is saying that this patient has tried multiple laxatives, has not shown much response. So he appears to have a refractory constipation and therefore he would want to investigate further. So what tests would you like to do in him, John?
Amit, can I make a point out here?
Yes, sir. Yes, sir.
The 2 points. Number one, that I think we should appreciate by the time patient comes to us to tertiary care centers or to gastroenterologist, constipation is not a disease. Most patients will come to gastroenterologist as a first visit. They would see their family physician at most places, be a small town, village, or even a big town. They hardly, some patient will come as a first consultation for constipation to GI. Before they come to you, come to a doctor, they all first apply their local homemade remedy and over-the-counter treatment. If they don't work, they go to family physicians or then they go to secondary and then tertiary care center. So by the time the patient comes to a GI at tertiary care centers, either on individual practice or corporate practice or on academic institutions, they already have gone through multiple level of trial of laxative of various kinds. Then they see us. So please keep that in mind that if you have already history of 5, 6, 7 years of treatment of constipation, then probably this style of giving more laxative without investigating may not be a great idea. Maybe we like to dissect out this more, that does he really need any investigation or not?
That's very true. That's why we said this role of this history examination is so important to know that this patient we have to proceed. And at tertiary care, you're right, the profile we see is like this only. Dr. Rathi, any comment you want to make, sir?
One more comment I'd like to make out here. So that we say that looking at the TSH or sugar, they could be associated phenomena. That is very less likely that somebody has hypothyroidism and come only with constipation for many years. Although we should do this test with the, mind you, that if your TSH was, say, in this patient was 12, but that's not a cause of constipation in him. With 12 TSH, if he has, his TSH is 3 or 3.7, but it was 12 or 14 or 15 or say, or even 100, classical hypothyroidism. His constipation is not because of hypothyroid. Hypothyroid might have worsened his symptom of pelvic floor dyssynergia, but this is not only hypothyroid. So we should also be aware that even in diabetes, even in hypothyroidism, there could be an additional disease which leads into constipation. These underlying metabolic disorders might be aggravating to severity of underlying disease which leads to constipation. Yes.
Dr. Rathi, any comments here before we proceed further?
George, we know that this patient has a pelvic floor dyssynergia. So would you like to do now manometry or other sophisticated investigations, or will you like to stop here?
So because he has refractory symptoms and he has tried different therapies, I would like to proceed further. I would ask for a inorectal manometry and a barium difficogram.
Yeah. So
what is the principle? Why you want these two tests? Or what you want to learn from by doing these two tests?
So inorectal manometry, we can look at the physiology of the patient. So how the rectum is behaving and how the anal sphincter is behaving to defecation. The second thing with barium difficogram is one, we can see how is the inorectal angle, is it changing with defecation, and is there, so we'll get more clues towards a anorectal dyssynergia, and hence we can confirm the diagnosis and treat.
So one is to confirm your diagnosis you will do. Any other advantage of doing these tests?
So if we do a inorectal manometry, we can advise for biofeedback therapy, which would be the mainstay of management in this patient.
And reassurance to the patient. So reassurance, biofeedback, and to confirm the diagnosis. Okay, go ahead.
So here you have the anorectal manometry, John. So you want to sort of interpret this?
So in this anorectal manometry, we can see that as the rectal pressure is going up, the sphincter pressure is also going up. So this would be suggestive of a anorectal dyssynergia type 1.
Can you show, put an arrow, Sridhar?
Yeah. So that's a normal area. And yeah, more towards the left. Yeah. So that's where the rectal pressure. So.
And the.
Yes, Sridhar, you want to show that, just go back. You want to show in that previous manometry, the rectal pressure going up and the rectal pressure also not improving or increasing.
Yeah, so this is the rectal pressure and this is the inner sphincter pressure that is increasing.
So I think as John was saying earlier that there are 4 types. I think in the type 1, the rectal pressure increases, but the anal sphincter pressure also increases. That's why it is a type 1 dyssynergy. So next you wanted to have a difficogram, John, isn't it? So here's a difficogram now. What do you?
So this is in the neutral position. So we can see that this is the anorectal angle. The perineum is well above the ischial tuberosities. And when he is defecating, we can actually see that the angle is not changed much or actually has decreased further. And if you see at the level of the ischial tuberosities, the perineum also has not descended much. So this is suggestive of a dyssynergic defecation.
See, anorectal manometry, one more point we didn't discuss was what is the role of this balloon expulsion test before we sort of say this. One more thing which we always do is a balloon expulsion test along with the thing. So what's the role of balloon expulsion test, John?
The balloon expulsion test is can be used as a screening method. So generally the balloon expulsion less than 1 minute is taken as normal. So this patient had expelled it within 30 seconds. However, he has other features to suggest that he has a dyssynergic.
Now that you have a barium difficogram result, now you have the manometry. What's your conclusion now?
So now I would, as these two are strongly suggestive of a dyssynergic defecation, my diagnosis would be a dyssynergic defecation, and I would manage him accordingly, sir.
So do you need any further tests like a transit study in this particular patient?
The only thing was at history he did not have an urge to defecate, and on examination he had this sphincter relaxation. So to confirm, I can do a colonic transit study to see if there is a slow transit constipation.
Dr. Govind or Dr. Rathi, any comments on this? What John is saying, the role of a transit in this patient?
Dr. Rathi, any comments?
What is the problem with balloon expulsion test in our setting?
It was normal. Balloon was normal in this patient. The thing is, what John is saying that this patient also, based on his history and assessment, the rectal examination didn't find much features of dyssynergia. So we say there may be overlap of transit with dyssynergic defecation. So there may be some chance of an overlap of transit. So he thinks it may sometimes be okay to do a transit study. So what's your take on that? Should you do a transit study or we should stop at that?
Yeah, there could be overlap of as the disease progresses, dyssynergic defecation can have a slow transit constipation. I agree with you. So there could be overlap. So to complete the workup, one should do transit study.
Okay. So we have the transit study in this.
So as
Can we put the slide for transit study? Next one.
Yeah.
So John, so this is the transit study pictures, X-ray at the end of the study. So how do you interpret this image?
So in this transit study, we can see various radiopaque markers. However, predominantly they are concentrated in the rectosigmoid region, which is again suggestive of a dyssynergic defecation.
That's again a very important point. If you look at this picture, what John is saying is that when you do a transit study and you do an X-ray, you also have to not only look at the retention of marker, but you also have to look at the positions of marker. In this patient, the markers are all in the rectosigmoid region. And so the right and the left colon is virtually free of markers actually. So when the markers are in rectosigmoid, then again it reflects a dyssynergic defecation rather than a slow transit constipation. Whereas if the markers were all over the place, you would have. So this patient, I think based on the manometry, you have a difficogram and even a transit study, although the markers are retained, but this will be read as more of a dyssynergic defecation than a slow transit constipation. Okay, fine. So what's your final diagnosis now, John?
So my final diagnosis would be a functional chronic constipation secondary to dysynergic defecation.
Next slide, please. So I think before we go further, there are a few questions in the chat box which we'd like to take. I think there's one question about some person is saying that which investigation should we do first? Should we do the marker, the transit study first, or should we do a rectal manometry first? So John, you would want to answer that?
So again, this will depend on the symptom profile and examination findings of the patient. So here, as we had suspected defecation dysenergy as the first differential, we would first do a anorectal manometry. However, because he also had some abnormal, some things which are not fitting in, we would also like to rule out an overlap and hence do a transit study as well. But first, we would like to do an anorectal manometry.
So again, that's very important. So I think the test you do really depends on what your clinical assessment has been, and you start with that test first, actually. Okay, there's another question that if there is structural abnormality like rectocele with dysarthria, do we still call it a PFD or pelvic floor dysfunction? So I think it's right. See, once you see a rectocele on a deficogram, that again tells you there is excessive straining. At the same time, the sphincter is not relaxing, and therefore the rectocele has formed. This again also reflects a pelvic floor dyssynergia. Other question is till what volume we should distend balloon for BET, the balloon expulsion test. So I think the standard is about 50 what we do. We can go higher, but I think most of our practice probably we stay at 50. Dr. Rathi, Dr. Govind, any other comments on that, sir? The balloon expulsion test?
With balloon expulsion test, yeah, I would like to say what we normally do in our practice is we ask the patient to expel the balloon when he is lying down the left lateral. Ideally, he should be going and sitting on a commode and expelling the balloon, which is difficult. So
Right.
that is a practical problem.
That's one of the same thing we do here. In fact, if the patient is expelling in that position, it's okay. Only if there's no expulsion, then you have to worry about the result. But if somebody is able to expel it in that position, mostly I think it should be fine. And for practical purpose, that's what I think many centers do actually. That's about. So in terms of volume, I think the balloon which we have doesn't have the compliance to go much more than, and that's the reason why we don't have, most of us don't have those balloons which can be distended to higher volumes. But that is generally helpful in checking for rectal sensation, you know. And here we are looking more at an expulsion. Obviously, sensation is also an important component of defecation. But in most of the practice, we don't test it because we don't have those balloons with much higher distancing capability. Other question is about this MR. So is MR defecogram necessary in all patients with defecatory disorder? So of late people are moving towards MR defecogram, and the question is MR defecogram necessary? So again, the MR, the benefit is that in the barium study you only know about the lumen and about the prolapse and the angle, but you don't know much about the pelvic floor actually. Whereas MR gives you a good idea about the pelvic floor thing as well. So the information wise, you get much more information in MR, but obviously it's expensive and not available. So therefore, for practical purpose, it may be still a barium defecogram in most centers. However, in our center now, slowly we have moved towards an MR defecogram because it's available and it gives you more information. Actually. Okay. I think there's another question about transit study. I think we'll take it up a bit later. Again, about the transit, how it is to be interpreted. Okay, I think there's a few questions about that. Another question is about any role of sigmoidoscopy or colonoscopy in this case. John, you would like to answer that? Is there a role of any sigmoidoscopy or colonoscopy in your patient?
So this patient did not have any alarm features. So, and his history examination is all suggestive of a functional constipation, and he has features to suggest dysenergic desiccation. So a colonoscopy or a sigmoidoscopy is not warranted in this patient.
That's very true. I think the studies have shown that the yield of colonoscopy is very poor. Actually, colonoscopy is mainly required when you have alarm features like some bleeding PR or weight loss, where you suspect an organic colonic pathology. Those are usually not very common. So usually not very helpful. Although if you look at guidelines for refractory constipation, some societies do recommend doing it in patients who are having refractory symptom and you're planning for like surgical intervention or something higher up, then I think we should do. Otherwise, usually colonoscopy is reserved for patients with alarm features. Mostly we don't do that. I think in the interest of time, we'll move to the management in this particular case. So Dr. Rathi, you want to take up the management with John and this patient?
Yeah, for that, the colonoscopy, what surprising finding you can find in this patient? Agreed, it is not required for diagnosis, but what all you can get information on sigmoidoscopy or colonoscopy?
Yeah, very important, John. Yeah.
So one is we can find fissures, internal hemorrhoids. Second thing is we can find the polyp, which may later increase in size. Any small mass lesions can also be picked up.
Anything specific because of straining? When somebody has a lot of straining in stool, any specific findings you see in rectum, John?
Any rectocele can be found. Intussusception can, or a mucosal prolapse can also be seen.
Any mucosal problem you see? Any ulcers you can see in rectum? So what is that ulcer called?
That is solitary rectal ulcer.
So solitary rectal ulcer syndrome. Yes. So SRUS, hemorrhoids, fissures, those you can see. Yes.
A long-standing patient is on laxatives. You can even find pigmentation, melanosis color.
Okay. So yeah, Dr. Rakti, management. You want to take up management with John?
How will you manage this patient, John?
So management, I would advise firstly some general measures and then specific measures. So general measures is I would advise him to increase his physical activity, increase his fluid intake. I would also advise him to set apart specific time daily for defecation, preferably within half an hour after a meal, and to try for around half an hour on the commode. I will also advise him about posture and also to elevate his feet by keeping a 6-inch block below his feet and try for at least half an hour. The specific management in him would be biofeedback therapy. And along with that, I would also give him maybe an osmotic laxative to soften the stool so that it can be expelled out better.
I think that's good. So essentially what you're saying is that some general measures as usual, then biofeedback therapy is the most important thing in this patient. So do you know what proportion of patients will respond to biofeedback therapy in dyssynergic defecation?
So around 70% of the patients respond to biofeedback.
Yeah, that's good. So I think that's good. So I think maybe because we are running out of time, 1 hour is over, we can maybe go to the second case and we can finish it. If anybody has, Dr. Govind, any comment you want to make, sir, before we move to the second case?
A couple of comments and this mainly for how do you investigate, the principles of investigations. So firstly, if you have a patient with chronic constipation, summarizing everything together of this case, that somebody comes with chronic constipation and you find there are clinical features which takes you towards dyssynergic defecation, then we need to have 3 important things to answer. That finger test or PR can tell us that you can confirm by 70% to 80% predictive value that this patient has dyssynergic defecation. So doing a PR will be a wonderful thing to do, even if you don't have manometry. If you have manometry at your center, please go ahead and confirm by doing a manometry. That's the most wonderful. But even if you don't have manometry, don't worry about it, because we as a clinician has to move forward. Even even we don't have clinical facilities and we do our best to our patients. So putting a PR, confirming on that, getting more evidence on per examination will add value to your diagnosis. Well, if you have a manometry, then there are 3 principles again to know. The first thing that you want to look at the overall evacuation process, and where you just do by balloon expulsion test, put a balloon, inflate the balloon, and ask the patient to pass the balloon. If patient is able to pass the balloon, it means what? The physiology of anorectum is generally normal. So a normal balloon expulsion test probably will rule out, or the prediction of having dyssynergia is much less. This is the first test, simple to do. One can even do a party balloon. You put over a catheter, push inside, inflate the balloon, and then and ask him to defecate, even without manometry facility available to you. A simple test can be done. We can do with our little amount of jugaad at our own centers. Third, if you have manometry, then you have will tell you, manometry will overall tells us what? It tells us the important process which are involved in the defecation. First, rectum will contract, right? And inner sphincter should relax. And this is what we measure in inner manometry. And based on that, these 2 forces, rectal contraction and inner sphincter relaxation, there are 4 types, which John has already discussed. Just to summarize, that normal defecation, rectum should contract sufficiently and inner sphincter should relax. But if there's a paradoxical relaxation or paradoxical contraction of inner sphincter, this confirms that there is a pelvic floor dyssynergia, and this is called type 1. And depending upon the rectal pressure or relaxation, we define type 1 to type 2, type 3, 4. So after we had done that, That's not end of it. We also want to know what the structural defects or structural abnormality in the inorectal apparatus. And this we can do by either barium difficography or better by MR difficography. Whatever available to your center should be fine. This can tell us a rectocele, pelvic floor descent, opening of a inorectal junction. So all of these can be seen by this. And this how you will able to pinpoint this patient have pelvic floor dyssynergia because of rectal push is not proper, or there's a inner sphincter relaxation is not proper. And this is how you will investigate these patients. One other point I want to emphasize here, that if you think of pelvic floor dyssynergia, let us not give fibers. If you give fibers, they will increase bulk of stool, and rectum is anybody loaded from before, it will worsen symptom of patient, it will increase more pain and more worsening of symptoms. So fiber is not a remedy for any patient with pelvic floor dyssynergia. In that case, as John said, that you like to use some kind of laxative. And what is the principle? That you want the stool to become softened. The longer the stool stays in rectum, they become more dry. If they become more dry, they're difficult to expel. And therefore, you want to do some kind of drug maneuvering which soften the stool. So you can think of what drug you can use. You can use polyethylene glycol. You can use some kind of paraffin, which softens the stool. You can use some kind of prochloropride, which can also add some water to the colon. But most often it will be a polyethylene glycol-like preparation will do good to these patients. So, once you do biofeedback, should give for a test. It's not about we need to teach biofeedback at our centers, but they should practice for a long period of time at their home. If they stop after 6 weeks of your effort in your hospital, most patients will go back to the normal after a certain period of time. So this is a biofeedback, like things are almost continuous efforts, because physiology is not going to change by that. Yes, Amit.
Thank you so much. That's an excellent summary of this case. So I think as we are running out of time, we'll probably have half an hour for the next case discussion. So thank you, John, so much for your case presentation. Let's invite Dr. Nicholas to present the second case.
Thank you.
So before Nicholas starts his second case, I would just like to recommend reading the Indian Consensus on Chronic Constipation. It gives a good primer on management of chronic constipation. So again, it gives a basic treatment and treatment of refractory chronic constipation. So it would be good if all of you can go back and read the Indian Consensus. So I think this has already been answered by John. So for the interest of time, we'll go to the next case.
I think we can skip this.
Yeah. Nicholas, if you can take over.
Presenting the second case. This is a 41-year-old gentleman, an engineer by profession from Delhi. His chief complaint was constipation for the past 30 years, that is since the age of 10. He gives a history of reduced stool frequency, less than one spontaneous bowel movement per week, without the use of laxatives. Also, his stool consistency was Bristol 1 and 2, which basically consisted of hard, lumpy, pellet-shaped stools. Predominantly, he gives no history of an urge to defecate. There is no history of straining to pass stools, no history of sense of incomplete evacuation or inorectal blockage. There is no history of any manual maneuvers to facilitate defecation, and there is no history of any abdominal pain. He also gives no history of prolonged fever, weight loss, bleeding per rectum, alternating constipation with diarrhea, abdominal bloating, vomiting, or feeling of lump per abdomen. There is no history of slowness of movement, neurological weakness, or bladder dysfunction. No concomitant drug intake like opiates, antidepressants, and calcium channel blockers. And there is no history of any comorbid conditions like diabetes, hypertension, or hypothyroidism. Past history, there is no history of any previous abdominal or inorectal surgeries. There is no history of trauma or injury to the back. Treatment history, In the beginning, he tried some fiber supplements like bulk forming fiber supplements like Isabul. Later, he tried multiple laxatives. He tried a combination of osmotic, both stimulant and lubricant laxatives, but all of which had only partial response. For the past 1 year, he's tried newer drugs like lubiprostone and prucalopride before coming here for a short duration with partial response. His Ayurvedic preparations have also been tried, but no real benefit. All drugs have been tried for an adequate duration of at least a month. Stimulant laxatives and osmotic laxatives, he says, worked initially, but then the response waned. He never had more than 3 spontaneous bowel movements per week. However, he does say that the Bristol form had slightly increased to a score of more than 3. He has been on intermittent enema, soap water enema, almost once per week for the past 1 year, with which he has some relief. The timeline of his osmotic and his fiber intake. Initially, he tried fibers in the first part of his illness. When he realized it didn't respond, he stopped. Later, he's tried osmotic and stimulant laxatives, and recently he's tried Ayurvedic treatment, which didn't help him much. Newer drugs like prucalopride and lubiprostone has been tried for a month. And now, before he's come to CMC, he's been on enema, soap water enema once a week. Personal history, he does not consume alcohol, he is not a smoker. He has an active lifestyle and regularly exercises. His appetite is normal, there is no history of any weight loss. His quality of life is generally good, although he is worried about his lack of urge to pass foods. There is no history of any psychiatric illness such as anxiety, depression, or obsessive compulsive disorder. He's never been on any antidepressants or any anxiolytics. His diet history is mixed diet, adequate calorie and protein intake, fiber intake has been adequate, and fluid intake is normal 2 to 3 liters per day. There is no history of any colorectal malignancy or constipation in the family. Summarizing my history, he is a 41-year-old gentleman with no comorbid conditions or addictions, with a history of chronic constipation for the past 30 years, with no urge to defecate, with a stool frequency of less than 1 per week, no alarm symptoms, and he has tried multiple laxatives and fiber supplements with only partial relief.
So before we go to the discussion, this is the second last poll question. So which of these is not associated with constipation? If you can just put up the poll, please. Hello. Yeah. So diabetes, mellitus, hypothyroidism, hypercalcemia, SSRIs, and calcium channel blockers. Okay. I'll stop the poll. So 159 people answered. So majority have answered correctly. 67% felt it is SSRIs, which is the right answer. 17% felt it was hypercalcemia, and 13% felt it was calcium channel blockers. So the correct answer is SSRIs. So so we need to know the okay. So we need to know the causes of secondary causes of constipation, and we need to rule them out in any patient who presents to us with constipation. Especially taking a very good drug history is very, very important. Drugs like any antispasmodics, ondansetron, any opiates, or even otherwise taking any calcium channel blockers. These are histories that that is very relevant to a patient who presents to us with constipation. So coming to the last poll question. So what is the
just one point out here?
Yes, sir.
That this is really important to look at drugs. Drug may not be the only cause of constipation in a given individual, but the drug might be precipitating, like second hit. So there may be a there may be a transit problem, there may be a pelvic dyssynergia, but they are compensated. They are not symptomatic, or they are mildly symptomatic. But the second factor on top of that may worsen. So therefore, these small things sometimes do help. That a good drug history, the control of diabetes, control of hypothyroidism, all of these add value to treatment of constipation.
Yeah, thank you, sir. Sir, going to the next last poll question, what is the likely type of constipation in this case? So, okay, so we'll end the poll here. So, 89% have answered slow transit constipation, 4% felt it was dysynergic defecation, and 4% felt it was mixed. So I think we'll. So just before we go into the discussion, something we need to understand about normal colonic motility. So there are two types of activity that occurs in the colon. So there can be segmental activity or propagated activity. Segmental activity is usually arrhythmic, associated with low amplitude contractions, and leads to slow movement of the colonic contents toward the rectum. It's usually for making sure that there is optimal contact between the colonic contents and the colonic mucosa for reabsorption of fluid, electrolytes, and the short chain fatty acids. Propagated activity, on the other hand, can be low amplitude, predominantly for movement of fluid, or high amplitude that usually precedes the sensation of defecation. Usually they are high amplitude up to 100 millimeters of mercury is the pressure. There is large movement of colonic content and may occur up to 6 times per day. And this is primarily responsible for the feeling of defecation that we get routinely. Okay. So coming to the discussion, sir.
So Nicholas, now that you have presented your history, what's your complete diagnosis now, clinical diagnosis?
So the syndromic diagnosis is of chronic constipation, probably functional. The type is slow transit type with inadequate response to osmotic and stimulant laxatives. No comorbid or concomitant drug use.
Dr. Rakhi, any question you want to ask at this stage? Dr. Rakhi connected.
Plus, your phenotype diagnosis is slow transit. Why do you say clinically it is a slow transit constipation?
So, one, because he's been having this constipation for almost 30 years, and his stool frequency is less than 1 per week. Second, is that because he does not have features of dysynergic defecation like straining or fecal or using manual maneuvers to help in defecation, or any sense of incomplete evacuation. Predominantly, the most important thing is there is no urge to defecate, which is in keeping with the diagnosis of slow transit.
So I think what Nicholas you're trying to say is that because there's no urge for defecation and the stool symptoms are just once in a week or less than once in a week he's passing stool, and also there are no features of a dysynergic defecation. So all that put together, you are favoring a diagnosis of slow transit constipation. Is that what you're saying?
Yes.
Dr. Govind, sir, you want to ask him something at this stage?
I think, no, just 1 second.
Now you're okay. Now we can hear you. Yes.
Please carry on. Please carry on. I'll join later.
Okay. So I think essentially this is again, so I think we already discussed in the first case about how do we know it's a functional organic. I think the previous one, the features are more favoring a dysynergic. Here, the features are more favoring a slow, and I think the audience got it almost 100% right. And it's most of them agreed this is a slow transit constipation. And here again, Nicholas, just to reiterate, how did you assess that there was an inadequate response to laxatives in this particular patient?
So in him also, in spite of trying fibers and osmotic and stimulant laxatives, his stool frequency never went up for more than 3 times per week. Though he does say there is some consistency improvement in Bristol scale. However, he still never crossed more than 3 times per week spontaneous bowel movements. That is why I'm saying that he did not respond to the treatment that was given.
I think then Dr. Rakhi, shall we move to examination? Anything you want to ask?
Nicholas, one question. What is the relation of methane producing bacteria and constipation?
So, there's been one study, I think from SGPGI, which shown that Methanobrevibacter's methii bacteria, when it is there in patients with when they produce methane, it is shown that there is evidence of that their motility is impaired, and that can sometimes cause slow transit type of constipation.
It can worsen the transit.
Yes. Dr. Govind, your voice, we can't hear you, sir. So you muted. So we can't hear you, Dr. Govind, we can't hear you. No, so we can't, we are not able to get your audio, sir.
Meantime, can we go ahead?
Yeah, please go ahead. Please go ahead.
Okay, I think, yeah, so we'll go to the examination here.
On examination, his pulse was normal, BP was 120/70, respiratory rate was normal, height was 170, weight was 67 with a BMI of 23.1 kg per meter square. There was no pallor, icterus, clubbing, cyanosis, lymphadenopathy or fetal edema. There was no thyromegaly and there were no cutaneous signs of internal malignancy that were noted. On inspection, abdomen was scaphoid with all quadrants moving equally. There were no visible masses, scars, or sinuses. There was no visible peristalsis. Palpation was soft and non-tender. There was no organomegaly or masses palpable, and there was no ascites. Auscultation, bowel sounds were normal. CNS examination, higher functions, cranial nerves and sensory system was normal. Motor system examination showed normal power in both the upper and lower limbs, and his VTRs were normal. Systemic examination, cardiovascular and respiratory systems were grossly normal. Looking at his digital rectal examination, on inspection, the perianal region appeared normal. There were no skin tags or hemorrhoids. Anocutaneous reflex was normal. Palpation showed no tenderness, masses, or strictures. The rectum was empty. Resting anal tone was normal. Squeeze pressure was good. Pushing and bearing down maneuver showed normal push effort with sphincter relaxation. And there was no blood on the gloved finger.
So what do you conclude from your rectal, go back to your previous slide. What do you conclude from the rectal examination, Nicholas? How do you interpret these findings?
Sir, his digital rectal examination was grossly normal. I didn't find any evidence of dyssynergia or any increase in or decrease in anal tone.
Okay. Yeah. Next slide. Yeah. So yeah. So we'll go to next slide. So does the examination change your diagnosis, or you still the diagnosis remains the same?
No, sir. I still stick with my diagnosis of chronic constipation with slow transit time.
Dr. Raki and Govind, anything before we move to the investigations in this case? Anything you want to ask? So your voice, I think we can't hear you, sir. I think there is a... So. Dr. Raki, anything you want to add meanwhile? Dr. Raki, anything?
No, I think you should go ahead.
So then I think what we'll do is we'll proceed to the investigations actually. Okay. So Nicholas, how would you like to investigate this patient?
In him also, I would like to ask initial metabolic profile of investigations. I would look for TSH, calcium, and sugars, and also check his hemoglobin just to see if there's any anemia.
Okay, so can we have those tests for him, please? So these are the reports. What's your interpretation of these tests?
So his thyroid level, calcium, and HbA1c is normal, and his platelets and HB is also normal.
Okay, so are you happy with this test, or you want to proceed further in this particular patient?
So these are the general investigations I would initially ask, but to confirm my diagnosis of slow transit constipation, I would order a transit study.
So the question is, why do you want to confirm your slow? I mean, what's the reason? Will you do it in every patient, or what's the reason for doing a test in this particular? What's the main reason you're going to test for transit in this patient?
So for him, I would like to confirm simply because of the fact that he's had refractory symptoms for the past 30 years. He's tried almost every treatment that is available to him and he's still not responded. So before I want to treat him further, I would like to confirm my diagnosis before I can offer him another therapy.
So that's a very important point. So if you look at this case scenario, it's about almost 30 years the patient has had symptoms. And I think his bowel movements have been about 1 or less per week. He's tried all sorts of medications. And finally, he's on enema every week for symptoms, and that is giving him some relief. So essentially, it's a truly refractory case. And obviously, on examination also, we didn't find any evidence of dyssynergia. Okay, so this patient, I think we'll have to probably think of further therapy. So we need to really characterize his constipation properly as to if it's really what type of constipation it is. So that's why I think Nicholas says he wants to have further tests. So what test would you want first in this patient, Nicholas?
I would like to order a transit study, a radiopaque marker transit study.
Okay, so do we have the transit study? So I think we can go to the next one, Sridhar. Yeah. So this is the transit study. This is the, so what picture is this, Nicholas? Transit, this is the baseline picture.
The first day.
Okay. We'll go to the next. Yeah. Go to the next one. Yeah. So how do you interpret this image?
So this is a plain X-ray abdomen, which is showing.
Sorry, before Nicholas, before you say how do you interpret, can you briefly just say how this test is done, and then you can interpret this image briefly. If you can say a few sentences, how this is done, and how do you interpret this image?
So how we do the test here is that we tell the patient to take a adequate fiber intake the day before the procedure, and we tell him to avoid any medication which will impede colonic motility, like any calcium channel blockers or opiates or antidepressants. And then on the day of the procedure, on day 1, before giving him the radiopaque markers, we'll do a scout film. Then we would tell him to swallow a capsule containing 20 radiopaque markers of different sizes. On day 1, 1 capsule. On day 2, second capsule. On day 3, third capsule. And on day 4, we will do the X-ray to look at the distribution of the radiopaque markers.
Okay, so I think so you're using markers of different shape on 3 days, and then you're taking an X-ray. Okay, so this is now the final image after the 4th day. And so how do you interpret this image?
So here, I would like to draw from the L file to draw 2 lines to both the ischial spines and divide them into right, left, and the rectosigmoid. You find that in this patient there is radiopaque markers of different sizes and shapes distributed both in the left and the right colon, but there is nothing in the rectosigmoid area, suggesting that there is some pan-colonic distribution of these radiopaque markers of different sizes, but it is not reaching the rectosigmoid area, and also that there is loaded stool in the right side and the left side.
That's very important. So if you look at this X-ray, the right colon is also loaded with stool. So definitely this also tells you, even if you didn't have a marker, you see there's so much of stool loading in the right colon, which tells you there is a slowness of transit. And obviously, when you're doing a transit study, as we discussed in the previous case also, that we are interested in looking at the distribution of markers, not the percentage retained alone. So here in this case, compared to the last case, what you can see, there are markers in the right colon, there are markers in the left colon, and there's hardly anything in the rectosigmoid. Last case, everything was in the rectosigmoid region. So this is what we normally see in a patient who has got a slow transit, where you have markers distributed right colon, left colon, everywhere, and most of them would not have got expelled at the end of study period. So I think this report, they did report that this as an abnormal transit study. So what will you do next, Nicholas?
So
this is the result now. So what's your next step, next investigation?
So after this, once you confirm the diagnosis, I would start management.
So in this patient, now that you know slow transit, you have sort of established, you still want to look for any dyssynergic defecation, because literature does say that about 20 to 30% patients who have slow transit also have a dyssynergic defecation coexisting. If that is the case, at least you can offer them some biofeedback, because this patient is not responding to therapies. He's on enema right now. And there is a possibility that 20 to 30% patients may also have a component of dyssynergic defecation with slow transit. So considering the nature of his symptom, the refractory nature, and what the situation he's currently in, would you also like to consider doing a manometry in this patient?
Yes, sir. Considering the fact that he's refractory and that there is some definite overlap of symptoms, which literature has shown that there is some dyssynergic defecation along with slow transit, which is possible, I would like to do a defecogram, barium defecogram, or a rectal manometry.
So see that we have any of those tests in this patient?
No, sir. So
Okay, so as I think that's one thing to remember, that while we say we classify them into, so one thing to remember in practical scenarios is that we put them into nice garden variety, slow transit, or dysenergia normal. There is obviously a degree of overlap. Okay, and we know that when there's a dysenergia, the biofeedback works better than the laxatives. So therefore, when you have a case where it's a truly refractory case, nothing much is working. Always remember that there is also a possibility of having overlaps in patients who are having constipation. And sometimes there may be a role of doing at least a manometry to see there's no dysenergia. Although rectal examination did not show that, manometry may be okay in this patient. Okay. So I think any other test you want to do, Nicholas, or you're happy with the investigations now?
So no, I'm happy with the investigations.
Dr. Govind and Dr. Praveen, any comments, sir?
So
Yes, we can hear you. Yes, sir, we can hear you. Oh, so now we can't hear. I think we were hearing for some time.
Do barium diffractography or manometry in this patient once the diagnosis is more or less certain?
Can you repeat your question, sir? I think for him, yeah.
Graphy or the Amit, please continue. Please continue.
Yes, sir. Now we can hear you. So please ask. Now we can hear clearly. Yes, sir.
So why do you want to do barium diffractography or manometry? Because see that if not needed, because a very specialized test and may not be needed in all patients unless we have a very strong suspicion of doing it.
Dr. Praveen, any comments at this stage before we go to management?
To manage, Nicholas, this patient?
So in him also, I would try general measures of lifestyle modification with adequate exercise and fluid intake.
See, Nicholas, this patient has a chronic constipation, has got colonic inertia.
Yes, sir.
He has constipated 30 years. Now, still general measures he'll keep on doing, then they will go 40 years, he will have constipation. So now he requires some remedy, no?
Yes, sir. So in him, I'd like to try the newer prokinetic drugs like procalcipride. I'd also like to try stimulant laxatives like bisacodyl and like cetosodium picosulfate.
That he must have had, taken in the past also. Now what you will, now he has come to you for, solace. He wants some solution for his problem.
Yes.
So in other words, when will you subject these patients for surgery, myectomy, ileostomy, antegrade irrigation, and you say enough is enough now, no more medical therapy?
So I would give him an adequate trial of drugs first, the newer drugs like the prokinetics, and see if he responds to that. In spite of this, if he does not respond, then I would refer him to surgical management.
So do you know what surgical managements are sort of available in a patient with refractory constipation?
Yes, sir. The commonly performed surgery is subtotal colectomy with ileorectal anastomosis. Other options, before they do that, we can check whether he's got a component of small bowel slow transit or even gastric emptying time problem. If that is not there, then we can give him a temporary ileostomy to help. And then these are some of the options.
That's, I think, again important. So we have to make sure there's no other concomitant small bowel or other myopathy, neuropathy, or sort of pan GI dysmotility, because in that case, the procedure may not help much actually. Okay. Dr. Govind, and any comments, sir, before we close this case?
Am I not audible now?
Yeah, you're audible.
Yeah.
Yes.
So what the surgery is the last resort. No, only surgery is not the option. We'll try all forms of colonic stimulant. Sodium picosulfate, once a dose, twice a dose. And can you go to of X-ray?
So we can't hear you. Now it's better, sir. Now it's better.
Okay. So can you show the slide of X-ray?
Yes, sir.
Yes. So look at this. Now we want to tackle this colon, and which is loaded with stool. So you can show the loaded stool by an arrow. So we need to do something. Whatever you do is not going to work, because the two things are there, that the colon is obstructed because of a dry stool, number one. Number two, that it cannot propel. So there are two physiological problems here, that the colon cannot propel the stool, one. Number two, there's a dry stool out here all over the colon. So even the colon propels, normal colon propels, this will not able to propel because this is obstructed lesion. So this is a long battle, not a short battle, it's a long battle. What do? We want colon to move. So that you use colonic stimulant, like you use sodium picosulfate or Dulcolax. If they don't work, you can even try neostigmine. Three things one can do: sodium picosulfate, once a dose, twice a dose a day, or sodium or Dulcolax, or even neostigmine. Start with 15 milligram and then you can go up to 30 to 60 milligram per day. Or pyridostigmine. You can use pyridostigmine for a longer period of time. This is number one. So you allow colon to contract. Second, even colon contracts, how do you move these stools out of the colon? You have to use something which can flush out. You use Peglec, use say polyethylene glycol. Okay, you give plain water, the plain water will get absorbed in the small intestine. Therefore, want a force from above. And what could be the force from above? Could be polyethylene glycol. So give polyethylene glycol, which slowly they will not be absorbed in small intestine. They come to large intestine and they will seep through the empty spaces of the colon and maybe take some stools down with it as they pass through the large intestine. So giving polyethylene glycol twice a day, once a day, depending on patient's symptoms, are the second thing to do. Giving only one kind of therapy will not going to work. Giving more fibers to these patients is further going to worsen. So no fiber for this kind of slow transit, because this whole colon is obstructed. Therefore, the strategy will be to allow colon to contract by using whatever drug we have. We don't have great drugs, but whatever drug we have is a sodium picosulfate, Dulcolax, or bisacodyl, or pyridostigmine. Second, give some kind of therapy which allow this the balls of stool to move down from right to left colon. So these two principles one need to use. A couple of more points I want to make here, that if you have this kind of X-ray and somebody comes to you with passes one stool a day, one per week, is nothing but slow transit. There's no doubt. If you have 1 week, once a week stool is fine, but if it's a history is repetitive, that's year after year or months after month, the patient passes one stool per week, even 2 stools per week, or even less than that, is nothing but slow transit constipation. They may be associated IBS, they may be associated pelvic floor dyssynergia, but the diagnosis is slow transit constipation. Therefore, all your treatment, all your investigation will be driven towards slow transit constipation. This is number one. Number two, the other point, that urge to pass stool. So then the first case we emphasized was anal examination or anorectal examination, which gives a lot of idea about anorectal function. Here in patient with constipation, urge to pass stool is very important feature. If somebody does not have urge to pass stool for days and weeks together, is nothing but slow transit. Or second thing is there is a rectal hyposensitivity. It means stool is coming to rectum, but rectum is not able to perceive its sensation. The two things, that rectal is not able to perceive its sensation, it means what? Rectal hyposensitivity, and which occurs in multiple conditions of those who have a neuropathic illness or myopathic illness, right? So more of neuropathic illnesses, and there are a number of them. True. So urge to pass stool, somebody doesn't urge to pass stool week, there's nothing but slow transit constipation. And third one, that if you have this kind of X-ray and if you don't have you don't have studies for doing a slow transit studies, then don't worry about it. You're almost sure. There's a patient with chronic constipation, long time, no value of no effect of your local laxatives. There's no urge, and stool and X-ray like this, is nothing but slow transit constipation. Don't bother if you don't have these markers. Most of us do these markers by cutting the NB tube, the nasopharyngeal tube, or some radiopaque catheters. We cut the small pieces, put in the capsule of say any vitamin, empty the capsule, fill these cut markers in the capsule, and improvise in your own setting. And one more point I want to make is if you go back to Sridhar to the Bristol stool chart, any of the slide.
Yes, sir.
This is a most underplayed or under utilized tool, which is a great tool. It's a great tool. I also didn't realize the importance of this, but once I understood the value of this chart is remarkable. Look at normal stool is type 3 and 4, which is a well-hydrated stool, which is a soft inconsistency. If you go up in the ladder, you have type 2 stool and type 1 stool. What is type 2 and type 1? Is more dehydrated. The stool was there, but it's more dehydrated. The colon has absorbed the water from this stool. Therefore, the surface becomes cracked. The surface not now, type 4 is smooth surface, but type 2 is a more rough, like cobblestone surface. It means what? Stool is dehydrated. And if a stool dehydrated, it breaks into small pieces. It's called pellet stools. These are pellets to type 1. Why type 1? Why type 2? It means this stool stayed longer in the colon. Therefore, the colon absorbed water from this, either colon or in the rectum. Therefore, they become dehydrated and they break into small pieces. So this is what type 1 and type 2, they are. Type 1 will tell you is something which is a more stasis in the colon. So this confirms either slow transit or rectal stasis in pelvic floor dyssynergia. So this is very important. And as you go down, there's more water. 5, 6, 7, more water means more diarrhea. Some patient will come to you with chronic constipation outpatient. It happens every time in outpatient. Patient tells me that I have constipation for say last 6 years. And if you show the Bristol stool chart on your phone, you just open the Google and open on your phone and show them. They say, I passed type 5 stool, but I pipe 3 times a day, but still say constipation. You know, this is not constipation. This is perceived constipation. This is the, if at all is a diet type of stool, is not constipation. So this showing this chart to patients is really changed at least my practice. And it's so easy to do. Open the Google, open this tool chart on the phone. It's extremely simple. Or keep this photo at your outpatient clinic and show to the patient that what kind of stool you pass. So 3 things I said was that if somebody has no urge to pass stool, if somebody has a very low frequency of stool per week, and third, if you have a stool chart type of type 1, you sure that there's a prolonged transit, prolonged stasis of stool in somewhere in the GI tract. And lastly, that many of these patients can have multi-system disorder or multiple sites of disease may be involved. If they have a dysphagia, if they have a gastrophagia or gastroparesis or bloating, then it's not a local colonic disease, it's a more diffuse disease. Amit.
Thank you, sir. I think there are quite a few questions, but because we now only have about 10 minutes left, I think I'll go on to my summary presentation if we can go for the next one, actually. So I'll present briefly about an approach to constipation, what we have discussed in today's meeting. So let me just share my screen. So are my slides visible?
Yes, sir.
Yeah. So just to summarize what we have discussed in today's couple of case discussion. So when you see a patient with chronic constipation, how do you clinically approach that patient? So as we have said, that it's a common clinical problem. And what Dr. Govind has been stressing repeatedly is that the patient's perception of constipation is different. And we need to have objective measures like a Bristol stool form scale, the frequency, etc., to know that, so we need to have some objective measures of assessing the nature and severity of symptoms. And because most of the patients with constipation do not require any specialized testing, they just need few baseline tests and you can treat them. So therefore, doing a good history, good clinical examination will really help us in deciding what patient we can manage without further tests, and what are the very few or a small select group of patients where we have to proceed for higher investigations. That's something to remember. That please remember, while we have been discussing this special tests like manometry, difficogram, etc., in majority of cases, those will not be required. Okay. So again, so the essential components of history which was covered in the presentations today is that we need to know about the duration of symptoms, what is the frequency, is the patient straining during defecation, stool consistency, again, very important, using an objective measure like a Bristol stool form scale. Does the patient have sense of incomplete evacuation? Is there a feeling of anorectal blockade or obstruction? Is the patient using any maneuvers like digital evacuation or pelvic floor support, etc.? And again, very importantly, does the patient have urge to defecate? So these are again cardinal features to assess when you're determining the nature of the symptoms. So frequency, straining, consistency, use of digital maneuvers, urge for defecation, etc. And again, so showing the chart to a patient is probably much better than you trying to interpret based on his description that what form it fits in. So always good to show a chart. So you can have a chart in your clinic which you can use and show the patient. It will be quicker assessment and more reliable than the patient description. Then once we get an idea about the symptoms per se, we should ask for associated symptoms like does the patient have abdominal pain, especially if somebody has a pain which is related to the bowel movement or associated with the change in consistency of stool, then we can think of an IBS constipation. Bloating is a very commonly associated symptoms in patients with chronic constipation. Look for any coexisting functional GI disorders. Alarm symptoms have been nicely discussed by Dr. Sridhar in his presentation. And also prior laxative is very, very important because you need to know what laxatives patient has used. Has he used them in adequate dose? Like Dr. Govind was saying that if even for slow transit, you should use adequate amount of a picosulfate or a bisacodyl or whatever. You should use adequate amount for an adequate time before you say somebody is not responding. Often what you see in practice is patient have skipped through multiple treatments without trying any of them properly. So you should have a proper idea about what the patient has tried before you decide your therapy. So this history is again very important to get. Then again, we need to ask history for any associated conditions or secondary causes of constipation, which can either cause or most often which can actually aggravate the symptom, as Dr. Govind was saying. So in a woman, any history of obstetric trauma, comorbid illness like neurological disorders, metabolic conditions like diabetes, hypothyroidism, psychological disorders, history of Hirschsprung disease, etc. Drugs, again, a very important cause of worsening of constipation, or they can cause constipation, like opioids, CCB, etc. Again, Sridhar has discussed this in his presentation. Diet and lifestyle. Is the patient taking adequate fluid in his daily? Is he on adequate fiber in his diet? How is his physical activity? Is the patient smoking? Because again, smoking can sometimes worsen the symptom. And also another important point which we should be asking is about the toilet pattern. Is the patient going at a particular time every day? Is he spending adequate time? Because some people may have variable timing. They are in a big hurry when they're going to the toilet. So these things may impact your bowel movements. So all these things have to be assessed when you are assessing a patient. And also how the symptoms have impacted his quality of life. Is there any family history of this condition? Okay. Examination, again, very important. General examination, systemic, covering all the systems, abdomen, neurological, etc. And finally, we have again emphasized in all the cases, both cases we discussed today, the importance of a good rectal examination. And again, Dr. Sridhar showed that if you do a good rectal examination, in about 70 to 80% of the case, you can get an idea about the presence of underlying dyssynergic defecation. So do not underestimate this. This is a very important test to do when you're assessing somebody with constipation. So once you have all that, then you have all the required inputs to decide that now, okay, this patient, what is the current situation? So constipation, is it likely to be functional or organic? Based on your examination, is it going to be a stain examination? Is it likely to be a dyssynergic defecation or a normal or slow transit constipation? How has the patient responded to laxatives? Does he have any comorbid illness? What other medications he's taking? So these are the inputs you need at the end of history examination to decide how to proceed further. And in most cases, at this stage, probably you'll just have to move to therapy. You won't need to go for higher investigations, actually. Okay. So the initial evaluation, as I told you, is good history and evaluation. If the patient has any alarm features like bleeding per rectum, or if there's any alternating diarrhea and constipation in an elderly patient, okay, if there's weight loss, we may have to do a colonoscopy. Otherwise, colonoscopy does not have a major, any significant role in evaluating patients with constipation. Okay, then we check for metabolic conditions. Okay, so once we have done this initial assessment, look for secondary causes, look for drugs, psychiatric disorders. Actually, we can move to therapy. We don't have to go for further investigation. So this therapy, as I said, Whatever underlying treatable causes there, if whatever we can manage, we should manage them. Lifestyle wise, educating the patient about the condition, importance of adequate physical activity, good amount of fluid every day, dietary fibers. And often we start therapy with a bulk forming laxative like psyllium. And among the drugs which are commonly used are Pegilec, lactulose, and magnesium. These are the osmotic laxatives. In some patients, when they don't respond, we can go to the stimulant laxatives like Bisacodyl, sodium picosulfate, or Senna. These drugs, I mean, there is always concern about side effect with long-term use, but however, studies have not shown them to be as bad as it is thought. So if you have a patient where symptoms are not responding, I think do not hesitate to try this long-term. Because remember, persistence of constipation can lead to other problems like fissures, hemorrhoids, prolapse, rectocele, etc. So I think if you have to use a higher level of drug, I think we should not hesitate because literature has not shown too much of side effects from these drugs like Bisacodyl, picosulfate. But again, they are not our initial choice. Initially, we use osmotic laxative. Then we go to the stimulant laxative. Okay. And finally, after trying all this, if the patient has not responded to therapy, that's when we call it as a refractory constipation. And those are the patients, select group of patients where we need to do these investigations. What we discussed in today's cases, we need a manometry with balloon expulsion test, a difficogram, and a transit study. Based on this, we can characterize it as a normal transit constipation if everything is normal. Dyssynergic defecation if the difficogram or manometry is abnormal. A slow transit if the transit is abnormal. And sometimes, as I told you, there may be overlap as well. So you don't have patients fitting all the time into this defined categories. Okay. And having this categorization is important because that's when you'll decide on the management. So again, the tests which we do are the colon transit. Again, it has been discussed. So transit study, there are different methods of doing. You do a single marker, take multiple X-ray. The example which we showed at our center, we give multiple markers on 3 days and we take a single X-ray after that. And there again, we divide the colon into 3 segments, the right and the left and the rectosigmoid. And we use the L5 spine as a landmark. Okay. And from there, you draw a line to the brim on the pelvis on the right side and the iliac crest on the left side and up in midpoint of spine above. Then you have the right segment, the left segment, and the rectosigmoid. And then you can assess what proportion of markers are retained in these areas and decide about a right colonic abnormal transit, left colonic transit, or a rectosigmoid retention. There are other methods as well, like scintigraphy and capsule, which are used. But the most commonly one is the X-ray method. Difficogram, again, it's been discussed, but just to reiterate, that in difficogram, you look at the anorectal angle. So anal line, you draw a line through the midpoint of anal canal and a line through the posterior wall of rectum. And this is the anorectal angle. So you look at this angle increasing. Normally, it should increase when there's a defecation. That's what you're looking at. You're looking at perineal descent, presence of any rectocele and any intersusception. Okay. And finally, for manometry, again, manometry, what we're looking at is the sphincter pressure at resting, squeeze pressure, what happens during simulated defecation. But this is what tells you about the different types of dyssynergia. Presence of any rectoanal inhibitory reflex and the balloon expulsion test. So if you look at this picture, this is the sphincter at normal. And then when the patient is trying to bear down or pass stool, then there is a pressure in the rectum and the sphincter relaxes. This is how normally it is. And when this mechanism fails, if the sphincter contracts, rectum doesn't contract adequately, that's when you get a dyssynergia. So this is my last slide. So once you have done a transit study, you've done a difficogram and again, the investigations you do depends on the symptoms you're dealing with. So first case, the symptoms are like a dyssynergic. So we began with the difficogram and manometry. In second case, which Nicholas presented, the symptoms are more sounding like a transit, and that's why we stopped with the transit study. So once you have a sort of classification, if it is dyssynergic defecation, then the main therapy in this group is biofeedback therapy. Up to 60 to 70% will respond. And as Dr. Govind was saying, that if you can give them something to soften the stool, like an osmotic or other one, then it will even help further in evacuation. But the primary therapy is a biofeedback therapy. The slow transit, which was the second case which we discussed, there again, I think the fibers to be avoided. And the drugs which may be helpful are stimulant and prokinetic. And again, do not hesitate to use stimulants, use them in good dose because patients will respond. Surgery, as Dr. Govind was saying rightly, is one of the last options and seldom done. In fact, I was looking at a series among the patients referred for surgery, less than 10% finally undergo surgery because surgery has its own issues. So really, you try your medical management as much as possible before you think of those drastic measures actually, okay? So, and we have now agents available like glucanolide, which can help us in a slow transit constipation. For normal transit, the options are a bit more and we can use any of them. So with that, I come to the end of my presentation. I think we have almost run out of time, so probably I'll have to stop. And so thank you to both Nicholas, John, and everybody on the panel for your participation, Dr. Govind, Dr. Rati, Dr. Sridhar. Over to you, Dr. Govind.
can take a couple of important questions.
Okay.
Right. So, I mean, the questions which are, I mean, at least we can take a couple of questions which are, I believe, are very, very important.
Yes, sure.
And at least the question which is, you use stool diary. I think Indra Kala Garis asked about use stool diary. I think this is a wonderful suggestion that if you give a stool diary to patient and see that how many stool they pass per day and how it improves with her treatment is a wonderful thing to do. And this is what most people will do. Other question, do you want to explain? Ashish asked about RAIR. Amit, want to take this? RAIR.
Yeah. So RAIR basically stands for rectoanal inhibitory reflex. So whenever there is a distension in the rectum, the sphincter will relax. That's so when you do a manometry, that's what one of the components you report during manometry is an RAIR. So RAIR is that when you distend the balloon in the rectum, the sphincter should relax actually, and that is something which is what is a normal response, normal physiology. Somebody has say an Hirschsprung disease or something, in those conditions the RAIR may not be present. So that's one of the features to suspect, although that's a very uncommon condition. Again, in patients who have dyssynergia, like that's what we are saying. And when somebody has a dyssynergia, when the rectum is sort of distending with the balloon for defecation, there is a paradoxical contraction of the sphincter. But RAIR classically is basically distending the balloon, looking for relaxation. One of the tests for patients with Hirschsprung disease, and abnormality is also seen in patients who are having dyssynergia.
There's another question which is again a very important practice point. I would believe that the role of fibers in constipation and when to start.
Dr. Rathi, you want to take up that question, sir? Role of fibers in constipation. What's your practice of fibers?
I think Govind will be able to answer that.
Okay, look at the fiber. Now, how this question of fiber came into being. So it came from say mainly for Western countries, and Western countries say about 30, 40 years back, the fiber intake was very low. You know that if you travel outside now, you find a lot of leaves in any of their lunch or dinner, because earlier people used to more refined food and fiber intake was very low. All societies of nutrition recommend at least 30 to 40 grams of fiber per day. And it's found that in the US and many other European countries, the fiber intake was just 20 grams per day. Therefore, the question came that why don't we use 20 more grams of fiber to improve constipation? This is genesis of fiber into in the arena of chronic constipation. So now coming to our own country, most people in all sides, north, east, south, west, majority of us, I won't call everyone, but many people have already gone Western diet in their own home. But majority of Indians, all sides of our country, north, east, south, west, still follow vegetables, fruits in their diet. And most Indians have a fiber intake of more than 40 grams a day. So adding fiber to that is not based on principles. So those patients who are not taking fibers, they will certainly we add fibers, but they will take a normal diet and they're getting enough fiber in our country. Second point is the second point. Second point is the second point is if you give more fiber to this patient, they will have more pain. So start with fiber in chronic constipation in majority of them, but again, be aware that these fibers may not add value to treatment. Sometimes it can worsen the symptoms some point of time. Yes. So other question was, the last question was, how do you do biofeedback and how long each session should last for biofeedback? So
I think biofeedback again, Nicholas, you want to try? I mean, okay, I'll just answer. So basically biofeedback, again, this is not right now available, although the number of centers offering it are now increasing. The thing is, it's a time-taking procedure, and also you need to have a dedicated staff who's trained well in doing this procedure. So basically, in a biofeedback, what we are showing the patient is in real time with the help of a manometry, that what is the abnormality which he's having when he's trying to pass a stool. So we use this balloon, distended balloon in the rectum, and there is stimulated defecation. And when he is trying to defecate, then we are showing the abnormality which is happening on the monitor in terms of rising sphincter pressure and inadequate propulsive force. And then we slowly try to correct that abnormality in that patient. That's the basic principle of it. And this takes about, ideally should be saying two to three sessions a week, and it should go for about 6 weeks. But again, because of logistic region and the resource constraint, this protocol may not be practical for most of the centers. For us also, we can't do it for 6 weeks, but we do offer them for a week or two. And then, as Dr. Govind also was saying, that once you teach somebody the biofeedback thing, the patient should be trying that. It's not that after you're trained in your endoscopy area, the work is done. The patient should be learning that, and then he should be trying it for a sustained period of time to get any benefit. Dr. Govind, anything you want to add to this, sir?
Yeah, I would like to add one thing about RAR, which somebody asked. You answer it is absent in Hirschsprung, but the most common cause of absent RAR is a technical reason. So you cannot diagnose just Hirschsprung on the basis of absent. Many times you get a report of absent RAR, people think that the patient has got a Hirschsprung.
So definitely, it's not a single test, but it's one of the characteristic feature in that situation. But obviously, as it's a rare condition and you don't diagnose it, you need multiple tests. You need a barium to show an empty rectum, a filled sigmoid. Even you need a full thickness biopsy to diagnose. So that's one of the indicators basically. But truly, I think it's not a diagnostic test basically. Right.
Like you rightly said, again at home you have to give biofeedback at 0, 1, 3, 6 months. It should not end with 6 sessions. It is a long procedure.
Yes. How is it in AIMS, sir? I mean, the biofeedback, is it how we, do you give longer period? Or?
We do weekly for 6 weeks. Sometimes we give also for 8 weeks. Because we so that weekly for 6 weeks, sometimes to 8 weeks, and we ask them to maintain a Cleveland Constipation score diary, and based on that we assess if they're improving. But we always encourage them to do these learning points at home and maintain that. Yes.
So I think it's one of, again, I would like to again just summarize that part again. That dyssynergic defecation is something of an ignored thing in our country, and because biofeedback therapy has such a good response rate in that condition, so if you can identify those patients based on the history and examination, probably those guys subjecting them to laxatives without correcting the physiological problem, I think is not a good way forward. So I think all of us probably will have to think about that aspect and try to get sort of biofeedback training and more freely available in our country and spend some time, because this means reduced use of drug, better response, and the patient's quality of life also will be better. So this is one area which I think is a lacuna in our country because of the patient load in the facility, but something to really improve upon.
I think with this has been a wonderful discussion today. A very important clinical problem of chronic constipation. How do we approach? Dr. Amit and his team had shown two classical cases of slow transit constipation and pelvic floor dyssynergia, which is the classical way they present. But again, no, many of these patients will have overlap. So this was just clinical case scenario, but again, patient will vary in our practice with various combinations. First to all the participants, this has been wonderful to see all of you here, and I hope these master classes making differences in your understanding of some of the clinical cases which we discuss here. You have been wonderful today because all the polls which Dr. Sridhar showed, you were all bang on right. It means that our understanding of disease physiology is wonderful. I think we must congratulate each one of you to putting the right diagnosis in both the cases. John and Nicholas discussed the case most wonderful way. Difficult problem, but they they discussed the case very appropriately. The history was remarkable. What we should ask, what we should add, and how to interpret the history into a clinical diagnosis. So thank you, John and Nicholas, and congratulations to both of you to making this panel a wonderful experience for all of us out here. Dr. Rathi and Dr. Amit, thank you so very much, because these two cases discussed very well, very important point brought, a lot of learning point put forward to our thoughts, and some of the malpractice or some of the misunderstanding have been resolved by both of you. Thank you so very much for participating in this masterclass. Sridhar, yes, as usual, you have been wonderful. Your questions you made were remarkable. I think they are very nice questions, and thank you so very much for your participation. So with this, we stop for today's presentations. We invite you to join next week again, or next Sunday, again, another topic, and this will be on approach to lump abdomen, which is also a very important clinical topic. How do you, make a diagnosis of a lump abdomen? So this case will be presented next week. Till then, thank you very much. Have a great Sunday and enjoy. Thank you so very much for watching this masterclass. Thank you, Dineshji. Thank you, Yogita, for organizing this masterclass. And we'd like to see you next Sunday. Okay, bye-bye. We can log off now.
Thank you, sir.
Thank you all of you. Bye.